I didn't say our Tortello.
Tortoriello.
Tortorello. For the record, just know, y'all know that I had this conversation with Dr. Bill before we got started. That y'all know it's either my Southern accent or something, but I butcher everybody's last name.
And
But
that's
that's okay
perfectly
because
acceptable.
by the next time you come to visit us on the webinar series, I will get it right. But I'm super excited. I know many of you are familiar with Dr. Cindy Howard, my dear, dear friend. She also happens to be a very close friend of Dr. Bell, and she recommended him and this topic for the webinar series. So you know this is a must-attend event for all of the people who were able to make it here live today. And for those of you watching the recording, well, I'm so sorry you weren't here live, but I hope you enjoy this presentation. But a little background, he's a graduate of National University of Health Sciences, which we were just talking about. To be honest, I think that some of my most favorite chiropractors that I am friends with are all graduates from National. It just seems to be a common thread. That's not to say I don't love the rest of you, no matter where you graduated from. But he opened his own practice, which was an integrative chiropractic clinic at the suggestion of his friend and mentor, who was a senior DNS instructor. Attended his first DNS course in 2007. And ever since, he's taken all varieties of DNS education offered, including all clinical and exercise courses. And he is really about to just really broaden our horizons, let us know a little bit more about this topic of discussion, which again was one of the ones y'all recommended that you wanted to learn more about. So why not go to somebody who has the background to really educate us and let us know? So Dr. Bill, thank you for making time out of taking time out of your busy schedule, and y'all, his schedule is crazy, for being a part of our webinar series. We appreciate it.
Oh, it's absolutely my pleasure. And again, thank you to Dr. Cindy and to ChiroHealthUSA. You guys have been very helpful and considerate and nice with me pestering you with emails for the past couple of weeks, trying to make sure this all works well. I really, really appreciate it.
Anytime. Will you take it away?
Okay, we're going to get right into it. Intro to Dynamic Neuromuscular Stabilization, or DNS. Just very briefly, graduated from National in 2006, immediately opened my own clinic, which may or may not have been the best idea initially, but I did, have been in private practice ever since. As you have already heard, I attended my first DNS course in 2007. After about 7 years of taking most of the courses, I got invited to Prague to take their final course and become a certified DNS practitioner. Within that 7 years, I had also gone through their track of pediatric courses as well, which allowed me to be one of the few certified DNS pediatric practitioners. So in addition to the typical clinical and exercise courses, I also teach the pediatric courses. Once after 2014, I started assisting courses, helping out with the courses, hosting courses. In 2019, I was asked back to Prague, invited to become a certified DNS instructor, and have been formally teaching courses ever since. So, a little bit of history for those of you who may not have any idea what DNS is, or maybe just a little bit. It is a framework for posture, movement, and stabilization based on human motor development, also known as developmental kinesiology, or DK. Developmental kinesiology essentially is the neurophysiology of the maturing locomotor system over the first 14, 16, 18 months of life. This is based on research as well as clinical experience and general theory. So it is considered evidence-based medicine. In one sense, too, nothing contradictory, nothing crazy about this approach. This is based on human motor development. There's textbooks written on human motor development. There's nothing out of the ordinary with this approach other than we are applying those principles to not only infants and children, but adults. We're using this perspective of neurodevelopment to guide not only our treatments, but our assessments as well as our functional approach to rehabilitation. Some names that are involved with DNS, or where DNS kind of initially came from and the ideas of DNS came from, are practitioners of manual medicine like Václav Vojta, Mojca Shova, Vladimir Janda, and Karel Levitt, all out of the Prague School of Rehabilitation, for those of you who may have heard of that. Now, the founder and developer of the actual DNS approach is a doc named Pavel Kolaj. He is originally a PhD in pediatric neurology, but is also a general physiotherapist out of the Prague School of Rehabilitation. A little bit special about Kolaj is that he was the direct student and protege of Janda, Levitt, and Vojta, and he is a PT. And a little bit about him is a little bit more is that he was actually named the head of the rehabilitation clinic at the Model Hospital in Prague. So he's a PT who was actually named the head of the physical medicine department, as well as he is the team physician for all Czech Olympic teams and all Czech national teams. So we've already started to talk about the idea that this is a principled approach based on development. So why babies? Why are we considering babies when we're talking about training athletes, treating older patients, geriatric patients, or treating your average school teacher? Why would we use this approach? Well, developmental kinesiology provides us with a universal objective framework that we can use to analyze all posture, movement, and stabilization. This framework is governed by a genetically hardwired program within the subcortex of the central nervous system. These programs outline developmental milestones, such as postural milestones, as well as movement skills that are associated with a timeline over the first 2 years of life. So let me repeat that. This is a universal objective framework, meaning this is not, Pavel Kolaj's idea of what stabilization ought to look like. It is not Kolaj's or the Prague School's theory of what a good posture ought to look like. This is what evolution hardwired into every human's central nervous system. Every human central nervous system contains these subcortical programs that are expressed reflexively over the first 2 years of life. And they are shared by every human, regardless of whether or not you were born in the Czech Republic, but in the Midwest, or in Australia. Every infant undergoes a very similar timeline of development over their first 2 years of life, and that's development of posture, movement, and stabilization. Kolaj and the Prague School just determined that, this is a very good framework and a useful objective framework to now base our movement and stabilization principles off of. So that allows me, when we're taking a look at our screen here, that allows me to say that, number one, the picture of the baby on the left is an approximately 3-month-old baby, possibly 4-month-old baby, based on the posture and the stabilization that they're presenting to me with. The picture on the right allows me to say, this is a similar posture, but the posture on the right for us is obviously objectively worse, less stable, less effective, and prone to dysfunction and then possible overuse and injury. Why can I say that objectively? Because it deviates significantly from the quality physiologic ideal posture shown by a normal functioning 3-month-old baby when they support through their elbows. Obvious things between the baby and the adult we have on the right. The adult has obviously a fixed or rigid kyphosis throughout the mid-thoracic spine, whereas this posture and this support strategy necessitates elongated extension throughout the spine. When a patient cannot attain that kind of posture, by definition, regardless of how much effort initially the strategy this guy uses on the right here, it is ultimately an ineffective posture and over time can lead to dysfunction. Similarly, we can apply some of the basic developmental milestones as well as transition movements that we're going to start to touch on throughout this introductory seminar to even things like recreational sports and professional sports. The pictures of these babies on the top and the bottom here, these are transitional positions from rolling from your back to your belly. They utilize a certain type of movement pattern, and that movement pattern facilitates muscle chains in a particular way. And that is the basis, those chains and these patterns serve as the basis for movement patterns for sports, for function, and daily life. Usually these are turning patterns when we're talking about rolling from your back to your belly. Turning patterns typically involve any type of throwing activity. So we see the tennis forehand, we see the javelin throw. These javelin throws, these tennis forehands, these swinging, pitching, spiking a volleyball, these are all functions of the turning process that is displayed initially in development. So I included this video just to kind of show us a range of the normal physiologic development of, I believe this infant's approximately 12 months old. And I'll try to outline or talk a little bit about what we're seeing, but we don't need to know everything. I'm just going to just play and we'll show it. So we have our baby lying on its side, obviously a nice quality roll over into a quadruped position, sits back through oblique sit into a nice tall sitting position. Sees dad over by the countertop. He's going to transition and crawl, reach up, place one foot in front of him to get to a high kneeling. Oh, not yet, not yet. Okay. He is going to place that foot. Oh, maybe not yet exactly. Again, a roll over into a crawl. These patterns of rolling, crawling, turning over, verticalization up to standing, these are all fundamental primary patterns of movement, development, and stabilization that for infants shows me as a pediatric practitioner that this infant's central nervous system is developing with quality. It's developing well. And because of that quality, because of the stereotype of quality that these infants display, or that we know from a quality developed infant, we know that those are the patterns of quality that can be extended to the adult population as well. Yes, and we see the full verticalization to standing. Nice tall stance support on both feet. Initially, child stands up and it's a bit more of an immature stance. They've got to hold on. Once they get a little bit older, they can rotate away from the surface. That tells you that number one, the baby is going to start to take its first steps. We just saw cruising along the furniture, drop into a nice little supported squat. Squat pattern is a function of normal development, which every human ought to be able to use. There's that half kneeling, stepping forward with one foot. So we have a front foot support, a back knee support, up to standing. Pulls up to standing. These are all patterns that, number one, are reflexive in nature, found in the subcortex. This is why we can say that these can be used for an objective framework of movement, because they're universal. They're shared by all infants. They're stored in every human's subcortex. We can also refer to them as a primary pattern because they are technically involuntary and reflexive. We'll get into a little bit more of the treatment approach itself, but first a little bit getting into the deeper understanding of how this development influences our posture, our function, and our structure. So, normal physiologic, which for DNS refers to quality development. The word physiologic means normal or quality. Physiologic central nervous system development is the prerequisite for high quality muscle function, which is essential for healthy morphologic development of the skeletal system. So essentially, it goes both ways. First, if I see an infant that is displaying patterns that I would consider quality, I would say that their central nervous system is maturing. It has a physiologic development. Therefore, the muscle coordination patterns coming out of that central nervous system have quality. Therefore, when those muscle coordination chains and stabilization patterns act on the bony structures and the joints, they are providing those structures with the most effective loading strategies and movement strategies that can be displayed. Vice versa, if I see joints that display unhealthy morphology or poor morphology, I can kind of reverse the track and say, okay, the poor morphology, there can be obvious exterior reasons for that, traumatic injuries, things like that, more significant inflammatory disorders. But besides that, the cause of these bony joint morphologies can be related to poor muscular coordination and stability strategies because of poor central nervous system maturation. So this concept goes both ways. So we can see poor postural strategies that can be occurring for a variety of reasons, but ultimately the DNS approach discusses and has a perspective that these poor strategies are a result of poor sensory information coming in through the support points. So for example, when you put somebody on their hands or a child in their hands, you can see that supporting through the hands requires a particular posture of the hand in relation to the wrist, in relation to the elbow, in relation to the shoulder, in relation to the spine. That relationship, that quality of support will influence the overall quality of the postural stabilization strategy. And if this child on the left continues to use this particular strategy for support for their head, neck, and shoulder, then you would ultimately see morphologic changes in the joint structures as well. That's all that we're saying. In one sense, not controversial. Poor stabilization strategies coming from poor development of the central nervous system will over time lead to joint dysfunction. That's all we're saying. And obviously, the opposite is with good quality stabilization through the hands in this case, you will get good quality muscle coordination, leading to good quality posture and less poor morphology of the joints. So, how do we explain development of posture in a similar way? Normal physiologic maturation of the central nervous system provides the foundation for posture, which allows for quality movement to take place. Now, when I look at an adult who has what I would consider an ineffective posture, a non-ideal posture, a poor quality posture, and even within that, I'm not talking about a static posture, but even a dynamic posture as they perform a function. Of course, we all understand that there are a variety of reasons that can lead to these poor quality postures. First of all, you can have a hemivertebrae, you can be missing ribs, you can have additional ribs. All of these kind of genetic and anatomical variants must be taken into consideration. Similarly, if we have nociception, if we're having acute pain, we all understand what an antalgic posture looks like and why it's there. So that can be causing the disturbance in posture that I'm seeing. Then there are more significant neurologic diagnoses like coordination disorders, cerebral palsy. These, of course, lead to postural disturbances. But more particularly, we're talking about the functional disturbances. We are talking about what occurs when the central nervous system doesn't mature as effectively or as normally as possible, as ideally as possible, but there's no hard diagnosis being made. Then this leads to poor quality mechanics, which then feeds into the joints and causes poor morphology, which leads to ineffective postures or what we would consider worse or poor posture. Remember, posture is the totality of all the sensory input coming in from the environment, gets integrated into the brain, and then filtered through all of our emotional experiences, as well as desires, anticipatory functions. So it is not just one thing that is causing or producing our posture, but a variety of things. That posture, I already started to note, we're not talking about posture only in terms of a static kind of neutral anatomical position, but we're thinking our perspective on posture is that it is dynamic. It's always changing. It's based on one's own stereognosis and body schema, and can not only be controlled consciously. I can place my hand in this position, place my head in a different position, but of course, our posture is governed by subconscious programs as well that we've already discussed that are facilitated and ingrained during those initial 2 years of development. Posture is the prerequisite for all motion and informs us about the quality of the intended planned movement that we're about to see. That can then lead to poor quality posture, which leads to poor quality movement and stabilization strategies. It does just simply go hand in hand. With an ineffective posture or a poor quality posture that is based off of our framework of development, we can then get an idea what type of quality the movement and stabilization strategy is going to be displayed at that point. Now, DNS also has a concept that we refer to as functional joint centration. Functional joint centration, the term itself refers to a particular biomechanical position in space. This is one perspective or one way of describing, thinking about, and talking about functional joint centration. But we need to understand that this is not just one particular biomechanical position. This is a dynamic position of the joint that always displays the greatest possible interosseous contact between the joint surfaces. That also means that it allows for the most effective load transfer across the joint and through the kinetic chain. When a joint is functionally centrated, by definition, we mean that the muscles around the joint and surrounding the joint will contract in a balanced, effective way that allows for the passive tissues like the cartilage, like the meniscus, like the ligaments, to be as protected and function as effectively as possible. So, just to outline again, the term functional joint centration does not just simply mean the neutral position of a joint or the anatomical position of the joint. Every one of these positions that you're seeing on the screen, whether it's the baby rolling or it's Federer serving, every aspect of every joint throughout this entire motion can have a functionally centrated joint position, meaning there are better ways for Roger to position and posture his shoulder here compared to other positions and ways to posture his shoulder. There are better ways for this baby to load their bottom hip as they turn versus other ways to load the bottom hip. And when it is in the most effective strategy, which means at the point at which the interosseous contact between the joint surfaces are at their maximum, that is considered the centrated joint position. It does not mean that the only centrated position is, at 90 degrees elbow flexion, 45 degrees of external rotation with 20 degrees of abduction. No, that's incorrect. At every moment of a dynamic movement, every joint has the possibility of being in its most effective joint position. We refer to that effective position as the functional joint centrated position. There is also a little bit of a deeper understanding of what we mean by joint centration. So if we take and assume that the joint is centrated, that the interosseous contact between the joint is at its most or at its maximum amount, then we can say that that input, that sensory input coming from the joint is giving the most accurate quality stimulus into the central nervous system. When I get good quality positive stimulus into the central nervous system, I then get the good quality output that we're looking for. When I have good quality central nervous output, that leads to maximum effectiveness of muscle tone, stabilization strategies, movement strategies, and muscle strength and range of motion. So in one sense, can I look at a picture and tell you whether or not a joint is centrated? I can get a pretty good idea based on the norms of biomechanics. Those norms do not come from strict biomechanics. They come from human motor development. They come from the norms that came and were developed from human motor development out of the first 2 years of life. So in one sense, can I get a look at a picture and get a pretty good idea of whether a joint is centrated? Yes. Can I tell you 100% certain that it's centrated? No. I have to be able to give a global exam before and after that contains a neurologic exam. And after the person uses their strategy, I look at it and say, yeah, that looked pretty good based on development, but now I'm going to globally examine you. And as long as your signs improve, then I know that you must have used a good quality centrated joint position. Because if you had not used that position, I would not get the quality changes overall in the nervous system on the post-assessment. We can talk more about it later if anybody has any particular questions about it, but that's, I think, as far as I'm going to go at this point. So at every aspect of this backflip, every joint has the possibility of being in a centrated position. Again, meaning the most interosseous contact, and then the deeper understanding of when you provide the most interosseous contact, that is such a good quality stimulus to the central nervous system that you have the best chance at effectively moving and stabilizing that joint through muscle coordination as well as the passive structures. So, if anybody has had any experience with DNS or has heard about DNS, they may have heard that we take breathing very seriously. So, number one, the ability to breathe and control our breath is the primary source of stabilization in the body. Number one, we have the respiratory diaphragm has three functions. I've already called it the respiratory diaphragm, so we're denoting one function. Obviously, it's the primary muscle for respiration. We all understand your diaphragm contracts. It causes air to be sucked in to the lungs, and you can breathe. However, there are two other main functions of the diaphragm. One is postural stability or postural stabilization. Through contraction of the diaphragm, we initiate our primary sagittal plane stabilization strategy as infants. That primary stability strategy also functions as a sphincter in the body. If we go back to our gross anatomy, we understand and know that the esophagus goes through the diaphragm. I believe it's referred to as the pyloric sphincter, and lets the food go into the stomach, which is below the diaphragm. If your diaphragm is not functioning appropriately, not providing the primary stability like it should, that causes the diaphragm to actually suck upwards, cephalad, versus caudally down. When it sucks upwards, guess what happens? Food from the stomach refluxes up into the esophagus. Now, I'm not saying that the 100% primary cause of all GERD and acid reflux is poor stabilization and sphincter function of the diaphragm, but it does have a direct relationship to that. So an indirect mechanical musculoskeletal way of treating patients with significant reflux is through primary sagittal stabilization utilizing a DNS framework. Of course, we have to take into consideration diet and inflammation and all the rest of those things. However, if you don't include that sphincter function through stabilization, you will be missing a primary function of the diaphragm. So we mentioned that the diaphragm, besides the respiratory function and sphincter function, provides us with stabilization. I'm going to essentially just give you the story of how this works. You've got the notes, you've got what's on the screen. What happens when you're a newborn baby lying on your back? Newborn babies have absolutely no ability to stabilize. They don't have any stability whatsoever. They do, however, use their diaphragm to breathe. That's exemplified by a very large ballooning out of the abdomen when a baby breathes, also known as kind of a frog belly. So you lie a newborn baby on its back, and it generally is moving everything. It moves its arms, it moves its hand, it moves its face, it moves its mouth, it kicks its legs. What you're seeing in that movement is total uncontrolled movement. And in reality, you're seeing a mirror into the midbrain. You're seeing a mirror into the primitive brain where the cortex and the central nervous system is not fully mature. So when it is not mature, it can't provide any stability whatsoever. By about 3 months old, a baby begins to coordinate diaphragm muscle contraction for respiration with abdominal wall co-contraction, as well as isometric contraction of the pelvic floor muscles or the pelvic diaphragm. When this takes place and a 3-month-old baby inhales, their respiratory diaphragm contracts and lowers down into the abdomen, increasing the pressure within the abdomen. When the pressure increases within the abdomen, of course, expands out. But in this case, by 3 months old, the expansion out of the abdominal wall causes a reflexive abdominal wall co-contraction, which controls the amount of abdominal wall expansion. Additionally, the expansion of the abdominal wall and the increase in pressure will push against your pelvic floor muscles. At 3 months old, those pelvic floor muscles now isometrically contract against this increase in pressure. So when you take that breath in as a 3-month-old and your respiratory diaphragm contracts, causing expansion of the abdominal wall, this time your abdominal wall muscles as well as your pelvic floor diaphragm contract against the expansion. The contraction against the expansion, known as, or what we would call a brace, that causes a significant increase in intra-abdominal pressure, or IAP. That IAP is the primary source for sagittal plane stabilization. As you can see in our animation here, on the right, we have the normal functioning of the diaphragm. This is normal function of the diaphragm without any co-contraction of the abdominal wall. We have lowering and we have exhalation. Inhalation, exhalation. But at 3 months, we can lower the diaphragm through inhalation, and we can cause a co-contraction that allows the diaphragm to stay in somewhat of a lowered position. Why is it able to stay in a lowered position? Because the abdominal wall co-contraction actively moves and pulls the lower rib cage down into a more neutral position. What we can see here is the idea that this breath is occurring 3-dimensionally, not only into the abdomen, but also into the thorax and chest. So we're not just talking about A to P breathing or filling the belly with air. We're talking about filling the entire abdominal wall with air. So you're not only breathing posterior and anterior, you're breathing out to the sides, obliquely, and even into the chest. This picture here displays the typical 3 to 4 month old infant that has now begun to coordinate its abdominal wall musculature, its pelvic floor musculature with its respiratory diaphragm. You now have an elongated position of the spine. The rib cage is no longer held up and out because of that abdominal wall co-contraction. This provides for the most effective stabilization strategy of your lumbar spine and pelvis. Therefore, this infant can lift its legs and hold them up above gravity in a stable way. This is the framework for our primary source of sagittal plane stability and can be the framework that we use to analyze all other activity, like this runner. How can I get a very good idea whether this runner is utilizing an adequate stabilization strategy? Because I have the picture of what quality sagittal plane stability looks like from our infantile development, and I now apply that to what I'm seeing in the thorax, lumbar spine, and pelvis here. We see a lowered rib cage. We see an elongated spine with no hyperlordosis, and they are able to move their legs, and in this case, his arms, and keep that pattern, keep that posture, which is considered the most effective posture to stabilize the spine from. As compared to something like this, what gives me the right to say that this is a poor quality posture, which therefore would elicit a poor quality stability pattern? If I saw an infant, a 3-month-old, a 4-month-old, an 8-month-old, utilize this type of strategy in an effort to load in an effort to transition and in an effort to move, I would call the pediatrician. The pediatrician would consider this a significant neurologic problem, or could be a significant neurologic problem. This is a sign that the central nervous system is not functioning adequately, did not mature adequately. That's why I'm able to objectively say this is a very poor stability pattern to load your spine with versus other patterns. Now, we've mentioned developmental patterns, and I talked about how certain patterns relate to certain types of activity. There are two main movement patterns that are found in development. One is an ipsilateral pattern. This is when the extremities on the same side of the body, perform the same function. So if we're talking about supporting function, if the support points in a movement or a posture are both found on the right side of my body, like in the picture here, the bottom extremities, his right bottom shoulder, their right bottom hip, are the supporting structures. By definition, this makes this posture and movement an ipsilateral movement pattern. When you have an ipsilateral movement pattern, not only are the supports found on the same side of the body, but the movement or the phasic extremities are found on the same side of the body. Also, the axes of the pelvis and the thorax will rotate in the same direction and essentially remain parallel when you are displaying and using an ipsilateral pattern. Now, it just so happens that ipsilateral patterns are involved with rotation and turning. Okay, now this is what we're talking about here. This is what we mean when we talk about ipsilateral patterns. We can see from the top the thorax as well as the pelvis are both rotating to this animation's right. Because the thorax and the pelvis are rotating in the same direction, this is an ipsilateral pattern. Now, when we see a dysfunctional pattern, we see loss of the actual stability strategy or the better, more effective posture because we don't get the abdominal wall coactivation, which helps to reposition the rib cage. In addition to the ipsilateral pattern, we have the contralateral pattern. If ipsilateral refers to the supports being on the same side of the body, while contralateral refers to the extremities on the opposite sides of the body having the same function. So this could mean either the supports are on the opposite arm and leg, or the phasic extremities, the movement extremities, are on the opposite arm and leg. In this case, the axes of movement between the thorax and pelvis will be generally parallel, but one axis moves in one direction, the other moves in the opposite direction. This pattern, or this contralateral pattern, typically refers to locomotion and verticalization and can be exemplified through walking, crawling, running, or going from a kneeling position to a standing position. These are all functions of a contralateral pattern where our thorax is rotating in one direction while at the same time our pelvis is rotating in the other direction. Similarly, if we don't get good coordination of the abdominal wall muscles, we have this, what we call an open scissors position occurring, where the rib cage flares, the lumbar spine goes into hyperlordosis, and you lose the effective posture that is required for quality stabilization. These are just some examples of how we use these ipsilateral and contralateral patterns. Remember, generally speaking, if you have to kind of keep it in the back of your head, anything where you're throwing or pitching or spiking, that is typically an ipsilateral pattern of turning. If you're running, if you're locomoting, if you're verticalizing from the ground up, this is a contralateral pattern or locomotion pattern. Now, how does this relate to general sports performance? I'm going to take a quick drink of water. Give me 1 second. The DNS perspective on athleticism is the automatic integration of our basic postural functions into a specific sports performance. This, of course, requires our ability to quickly and effectively transition between one posture to another and one motor pattern to another. It also requires us to modify these postures and to modify the motor patterns. And obviously, whether or not you're using a racket or a bat or a golf club or a hockey stick, you have to then integrate tools into the overall movement patterns, which, as we all know, changes vectors, changes force, changes load transfer across the kinetic chain. This is the definition of why sports performance is much more complex and much more difficult to effectively load and effectively perform than your typical activities of daily living. Now, the goal of training is to obviously increase our body's resiliency and adaptability to load, while, of course, respecting our individual patient or client's functional thresholds. What does this mean? It means that when we do begin to load our patients into positions, so not only the load from gravity, but also the load of adding in your hockey stick or your baseball, but maybe the load of actual doing strength training exercises, DNS still requires quality. We prefer quality over quantity. So the only way we allow people to continue to load or increase the load is if they can demonstrate to us that they can move or sustain that load with quality. We also, if we want to see improvements over time, we obviously have to increase and sufficiently load somebody. If someone, through their job or through their sport, requires a significant amount of loading, they will have to spend time training that load. So this is also a consideration. In addition to the amount of load or the intensity of load, we're also talking about endurance, we're talking about repetition, and we're talking about frequency. These are all standards of training, but ultimately the DNS perspective says that these still have to follow the general rule of we have to pay attention to quality. You have to be able to brace and breathe effectively in any of these movements, utilizing any of these postures, whether loaded or not. Now, how do we use DNS as an assessment? We've already started to talk about it, but essentially what we're doing is we are comparing the optimal movement patterns of stabilization that we know from development with what we are seeing our patients do. So we can place our patients into these positions, ask them to perform them, or we could ask them to perform their particular movement, and we are analyzing and critiquing and assessing what they're displaying based on what we know comes from good quality stabilization from development. At that point, what we define as quality is the ability to change the shape of the abdomen into more of a cylinder or barrel. This requires functional joint centration through elongation of the spine and allows for balanced muscle tone and quality of support. Every position has support points and particular aspects of joint centration that we want to see, and we're looking at that when we're doing this assessment. Now, in DNS, we have a variety of tests based on these patterns. We're not going to go through them all, but essentially every developmental milestone and transition can be used for a test, assessment, as well as treatment. This is the IAP test. Again, this shows us what the very first time an infant, or a human for that matter, displays the ability to stabilize their low back and pelvis. So we can ask our adults to try this and see how well they can actually do it. Obviously, if they can't do it well, or they have pain or dysfunction, they can't get into the position, this is a sign that our patients lack good quality primary stabilization and is an access point to treatment. The corrective exercise strategy from DNS comes directly from the testing. So if my patient cannot lie on their back, effectively stabilize their lumbar spine and pelvis, and lift the legs up and off the ground, well, that's where we're going to start. DNS provides us with a framework for regression, how to make this a bit easier. It also provides us with an understanding of how to make these things harder. Harder can come through just simple quantity. We're going to do it longer. We're going to do it for more reps. We can load the position, and we can also start to move from the position. All of these things are the typical things of training that make an exercise position harder. I do want to reiterate, though, that these are not just static positions on the floor. These are transitional movements that move from one position to the other, including upright, walking, running, squatting, lunging, loading, things like that. So, essentially, some rules. We are training ultimately the primary patterns of stabilization and movement. We're applying those principles then to your normal strategies of daily living. And if you are performing recreational activities like sports, or your actual work requires some of these things, we integrate that into the training as well. So whether or not you're a 3-month-old baby or a CrossFitter or a construction worker or grandma who wants to pick up their grandchild off the floor, these strategies don't change. The patterns don't change. How you apply the pattern changes, and we can train those. Right? We have a deep squat at 12 months old. We continue to utilize a deep squat, or should you be able to utilize a deep squat throughout our life. Like I said, this is just a particular example when you want to look back at the notes of how DNS can utilize a particular contralateral pattern to train in an upright position. And we are facilitating particular muscle activity for particular extremities, utilizing these developmental strategies and positions. The DNS perspective on sport just extends from there. We are using it for prehab, essentially the prevention of injury. We think of it as when you are constantly reinvigorating these primary stability patterns of stabilization, you're building up your body's credit. Because obviously not every single movement is going to be perfect and needs to be perfect. But when you build up that credit through constant daily awareness and daily routine of exercise using these strategies, then when you do start to move or utilize less effective positions, they don't harm you as much. They don't cause as much dysfunction. Of course, if you actually do get injured, then we use this as the primary source for rehabilitation. And we believe that when you utilize these strategies to the best of their ability, they will allow your performance to go up, up, and up. The best sports performance obviously requires you to maximally load. So we are trying to reach each patient's functional capacity, which we've talked about is the place at which, the threshold at which your strategy of stabilization movement remains effective and ideal and not crosses over into the more poor strategy that can lead to injury and dysfunction. Just because we can move properly doesn't mean you will move properly. Maintaining proper movement strategies in sports requires having the functional capacity to actually handle the challenges of your sport. So it does need to be trained. Just because a patient or an athlete can show me something that they have adequate joint range of motion doesn't mean they're going to be able to stabilize that range of motion in all positions. Needs to be trained. Just because this athlete over here appears to have muscle tone and strength doesn't mean when they actually load through their hands and press that they will be able to do so effectively. And actually, she is displaying a newborn pattern, a protracted internally rotated shoulder, a reclinated neck, flexion in the lower extremities. I don't want to reflect an unstable newborn when I'm exercising, right? That is essentially the DNS perspective. Just one note on breathing. I'm not going to read every aspect of this. It's for your reference. But number one, DNS describes breath as primarily beginning in the abdomen through the diaphragm, but expands into the thoracic cage. Chest breathing is perfectly normal, but there's quality chest breathing and poor quality chest breathing. Quality means expansion in all directions, obliquely, A to P, as well as laterally. You want to see the entire abdominal wall and thoracic cage expand. We don't want to brace down in our abdomen and only force air into our belly, not allowing any breath through the chest. That is poor quality. And why can I say that? Because we don't see infants breathing like that. Normal quality breath of the stable physiologic infant displays good quality chest breathing. So to conclude, understanding the utility of human motor development is essential. If you are someone who deals with posture, movement, and stabilization strategies, it forces you, it's a necessity to understand how we developed naturally our posture, movement, and stabilization. DNS provides us with that framework and allows us to assess and treat in a natural, effective way. If you want more information on DNS, the DNS website is linked below. It's rehabps.com. There's also, they have online tutorials and videos displaying hour-long lectures on how they treat runners to 10-second little animations for particular exercises. If you want more from me, again, I am a DNS instructor. I teach DNS seminars. The company, or my own company that I teach through, is called IMTR Seminars. You can find me on Facebook, Instagram, YouTube, and Spotify. We have a podcast called IMTR Grand Rounds. It's a 10-minute weekly podcast. These are some of the courses I'm going to be teaching over the next 6 months. If you want to contact me directly with any questions, please email me at drbill@imtrseminars.com. I think that's all for me right now. If we have some questions, I'm ready to take them.
Thank you so much, Dr. Bill. We have one that says, please re-describe the diaphragmatic breathing technique to attain the downward depression level you were speaking of.
Okay, so I'm going to click off of that. So the diaphragmatic technique that I'm speaking of, number one, when you breathe simply using your diaphragm contracts. It lowers into the abdomen. You get an expansion of the abdominal wall, right? When you get that expansion, you are also coordinating the expansion with abdominal wall muscle activity that helps to lower the actual rib cage. It pulls the rib cage down. So technically speaking, again, when you look at a newborn that has no stability whatsoever, its rib cage is flared up and out. It has a hyperlordosis in the lumbar spine. By 3 months, over the newborn to 3 months, by 3 months, the abdominal wall muscles have been slowly reacting to this constant ballooning out of the abdomen. By 3 months, the abdominal wall reacts so much that it literally pulls down on the rib cage and neutralizes the lumbar spine, neutralizes the thorax, lowering it down. And that position of the lowered rib cage, neutral lumbar spine on the pelvis allows the diaphragm to effectively pump and stabilize the low back and pelvis.
And then
that get at it?
Yes. And then the follow-up to that was, is there a visual somewhere that they can download to give to a patient to help them apply that breathing strategy?
Well, honestly, I would say, if you, I don't want to sound like a used car salesman. If you look up IMTR on YouTube, I've got videos on there that demonstrate these exercises, these positions. If you look up my name on YouTube, there's videos and exercises with adult patients. There's a variety. If you start Googling DNS, there's pictures online that you can see. Of course, if you go directly to the DNS website, they have a bunch of pictures on there as well. What I would say is that word barrel and cylinder is appropriate. When you look at an abdomen that is stabilizing with quality, you see no concavities or convexities. You see no sucking in or hollowing out. You see no scalloping. You don't see a huge six-pack. You literally you should see kind of a smooth, rounded barrel. Now, it's not bloated out like a frog belly. It is just symmetrically out. That is a cylinder or a barrel shape. That's what you kind of want to see. And that's what you can see in a 3-month-old. And that's what you can see with somebody who displays good quality stability.
I love that. And I do love that you recommended going to YouTube, because I think people learn so much from videos.
Sure. I mean, I might go to my YouTube because I trust what I'm putting on there versus one person who took one DNS seminar putting a bunch of videos up. It might not be the most effective that they're showing, but we can try.
Wonderful. Well, again, Dr. Bill provided y'all with an email address. So if you're like me and think of questions after the fact, don't hesitate to reach out to him. Thank y'all so much for joining us today. Dr. Bill, thank you so much.
Oh my God. Thank you guys so much. Again, you've been so helpful and considerate over the past couple of months. I really appreciate the opportunity. Thank you.
You're very welcome. All right, everybody. So we'll be back in 2 weeks. Dr. Otto Junkie is going to be here for the next webinar. You can go to our website at ChiroHealthUSA.com/webinars to see all of the upcoming webinars, most of them through the end of the year. So we've got some really great people. I'm really excited about the next couple months, man. Like we're kicking it right back into the fall with some really great ones. Dr. Bill, thank you for kicking that off. We'll see y'all next time, same place. Bye, y'all.
Thanks.